So welcome, another episode. Absolutely. It's so good to be back, and we've got a fantastic guest today. Hello from myself, Amit Paik, and we've got Paul.
I'm on the wires as usual, just keeping them right.
Yeah, saving the day, mate. Well done. Thanks so much.
We try.
And I'm really pleased to get with us on the podcast Dr Vicki Trotter. Vicki's here to talk about women's health specifically, so keen to hear more about her thoughts, reflections on that. We've got a bit of a story about being incredibly supportive for me during my training. So Vicki, go on, over to you. Introduce yourself.
Yeah, hi Amit. Lovely to see you again, and Paul.
Hello.
Nice to see you again as well. So I'm Vicki Trotter. I'm a GP partner in Brampton Medical Practice. I've been a GP now for nearly 10 years. I know Amit previously from my time working in Colbeck.
Yeah, absolutely.
He was a
Go
registrar with me. Yeah, absolutely.
Yeah.
And I was one of the GPs when you were towards the end of your training. I love women's health. That is really why I went into medicine. I actually was always probably a gynaecologist at heart, but went into GP. And I was very close to doing my obstetric gynecology training when I was told by a brilliant menopause expert in Newcastle, Dr Mansour, and she sat me down and she said, actually, we need more GPs really good in women's health. And she was like, look, your skills will be much better, and there's probably a lot more scope of women you can help in primary care. And that conversation did change everything for me. So I went into primary care training, and I'm quite pleased with the career that I've had so far and the clinics I do. So I work 7 sessions, and most of my face-to-face clinics are mainly just seeing women actually. So I have the 2 diplomas in obstetrics gynecology, a diploma in sexual and reproductive health, so the DFSRH, and I've done quite a lot of extra training in menopause, HRT work as well.
Amazing. I would be really keen to get you on the podcast, really from a women's health angle. Such a massive part of primary care, isn't it? But if I'm going to be honest with you, and I'm, as a bloke here, there's always a few anxieties about women's health. Am I doing it right? You can read the textbooks, you can do the exams, but actually there's a degree of complexity. So it's so good to be able to unpick some of this with us on the podcast. So thank you so much for coming along. Let's just go from the very beginning. Where are we with women's health in primary care? What do you think we do really well? What do you think we need to do better of?
Yeah, should we start with the things we do well?
Yeah, go on, let's do it.
Yeah, because I guess I've got a lot of thoughts of sort of a way forward we still have got to make.
Go on.
I think the things we do well is we are the only clinician in all of medicine, I believe, that can help women the most. I guess you think of it, I see women's health so embedded in the rest of all of our experience of our life and our health. So we have kind of our physical health, our chronic health issues here. We have mental health issues, we have women's health. And I think most doctors often compartmentalise these issues, but they're really, really not. Like the whole existence of a woman, they're all interlapped. You know, our experiences of our hormone health, our cycles, our constant change in our bodies, it changes so much in our life. I'm not trying to disregard men's health at all. I'm sure that could be another topic. But actually, we need to understand the whole woman. We need to understand everything in their life. And I believe, as a GP, we're one of the only specialities where we can sort of see everything as a whole. Yeah,
I mean, absolutely. Look, we're generalists, aren't we? And particularly from GPs or even across primary care, our colleagues practice very generalistic medicine. So you're right in some ways, rather than focusing on a particular niche area of the specialty of gynecology, we can actually have a breadth. And look, I've got an appreciation of cycles have a bearing beyond the hormones. Environmental has a big impact as well, potentially. So I kind of get it.
So the things we do really well, I guess we can see all issues for women of all ages, from kind of first periods to considering pregnancy planning and conception advice, pregnancy complications, bleeding problems, period pains, very heavy period, to then kind of later into life, kind of the perimenopause, menopause, prolapse issues, pelvic floor issues, recurrent UTIs, recurrent thrush. I mean, I've probably...
Massive topic.
Yeah, I could probably spend your 20-minute clinic just listing out the problems. However, what I would say is that I think we're lucky, and we're in that really unusual position that we look after women for decades. We look after their whole families, and actually knowing the context, as other things in primary care, is so important. What's amazing in Brampton, where I trained in, say, 2012, there were women that I was helping and seeing through their pregnancy, and now I'm seeing those same women maybe approaching the perimenopause, menopause, and having issues later in life, but also treating those families, spanning that whole time and getting that context, knowing the impact, their relationships, their work, their home life, like that's crucial.
When somebody summarised it in such an amazing way, Vicki, actually we do a flipping good job.
We do.
Careful my language. Blimey.
Yeah. I don't want to be beeping on this thing. Yeah.
Vicki, look, an amazing summary. let's flip it. What should we be thinking about focusing on then? Come on.
I think it's difficult. I think in general we should say that I think women's health, it's good. It's now getting a bit more of a platform in the media, on social media, in the news. I guess as women, we talk amongst our friends and family much more about those more intimate and personal conversations. But I think with that, there's a lot of misinformation. And I think it's great that women are maybe a bit more empowered to come to primary care now, but I still believe that women are often presenting far too late. I mean, I reflect in my practice now, and I'm really worried. I'm having a lot of the later conversations when issues are getting into crisis mode. I wish I saw a lot of these women maybe months, years ago, where we could have helped them much more. Maybe the burden on the disease itself, the treatment options would be much easier if we helped early on. I think actually the burden then on the NHS when an issue is left much later, it's much harder to treat. It maybe goes beyond primary care competence. We're, adding to waiting lists. So for example, I don't feel I've seen many teenagers to just talk about safe sex with, whereas that was quite common a few years ago. Again, the earlier menopause, perimenopause symptoms, that's quite rare. We're seeing things much later on. And again, issues and first problems with kind of period irregularities. Again, that's quite rare. We're seeing much later on. People have suffered in silence for kind of months, years. And actually, there's a lot we could have done to help.
So it's encouraging them to come forward almost?
It kind of is encouraging them to come forward. And I guess my worry and why I was quite empowered to come today is I think digital triage, obviously the government initiatives, we have to be offering, online portals for women or patients to seek help. But actually, how far are they maybe discouraging those more personal, intimate conversations? And I think it's really important that we acknowledge that and we kind of reach out to women and we make it really clear that these conversations are still really important, and please still seek that help.
It's so important because I completely agree with you, Vicky, that there is a whole bunch of patients I end up seeing in clinic that I present very late, and they've been months, they've been struggling with symptoms of menopause or bleeding, and they've been reluctant to come or they've sat on them. So I kind of agree that there is an element of that. Beyond increasing capacity, I mean, I'd love us to say that there's suddenly hundreds of appointments where we can see people from there on. But what else do you think we could do in primary care to try and support? Yeah,
I think that's really important. I kind of believe, I think there should be more training on elements of women's health. I think it's maybe a bit more complicated, but for example, if we take menopause and HRT, for example, I do believe that probably every GP should have a basic competence in HRT. It's very rare, but occasionally you do see women being told that they saw the doctor and they just completely turn them away for HRT. Now, there are some scenarios where HRT is contraindicated. We sadly can't give it because it's very dangerous or unsafe for a particular reason. But there's many more women where, there may be cautions. We need to be quite mindful, but we could be pragmatic, we could look at things differerently. And I am surprised in this day and age that there is sometimes, I could be wrong, but some women tell me that they're turned away or they're dismissed, and that does worry me. So I suppose I would really like there to be like a minimum competence requirement for if we're prescribing or seeing women for HRT. I think there should be more training to primary care clinicians for a better general understanding of HRT itself. I also believe that maybe this probably goes back to capacity, but if we could have the ability of a longer appointment for a woman, because again, as we mentioned, sometimes there is a bit more complexity to the case. Again, maybe more specialist tests and examinations that may take longer, that it seems crazy. We might get a 10 or 15 minute consultation for a sore throat, but the same for a woman. And I feel like actually they do require different timings.
It's true. There is a degree of complexity here. And I think even when I, for example, see patients in clinic who woman comes to see me about HRT, there's always an element, oh my God, all right, so I've got to go from the top. And I've ended up even learning, having resources to hand on a folder on my desktop of step-by-step process of looking through HRT. But it still causes some anxiety for me, if I'm honest with you. Just thinking about our trainees and individuals who are just coming through into primary care, anywhere you'd recommend to go and get some of those resources or keep some really good high quality stuff in mind?
Yeah, absolutely. I guess we're very grateful. Obviously, Nice CKS, I'm sure as every trainee's heard, that is excellent. That's a brilliant guide.
Absolutely brilliant.
But when it comes to more women's health issues, that's still a great topic, great resource. But we do have the Faculty of Reproductive and Sexual Health. They've obviously got the UK Met guidelines. That's a great resource. kind of quick PDF pop-up. They again have quick summary guides to contraceptive issues, unplanned pregnancy, unprotected sex guidelines. A lot of those are great, and they're really colourful pop-up and a quick flow diagram. The BMS have excellent resources.
BMS?
British Menopause Society.
Oh, yeah.
And I guess crucially over the last year, we've had a lot of hot topics and guidance around the use of kind of weight loss drugs and medicines when it comes to contraceptives, HRT. So they've got good resources on that. And again, a big change, which I feel like primary care, I could be wrong, potentially need to have more training and understanding in is the unscheduled bleeding on HRT guideline. So I think that's a really helpful resource, and I really would point every trainee and GP to look at that BMS guidance because it has changed quite a bit over the last year.
Oh, really? Okay. No, really interesting. I know there's a bunch of courses that you can go on as well, which obviously cost X amount of money from there on, but good to know that there's resources. And I think just from my experience, just thoroughly recommend people just have a folder on your desktop where you've got a quick reference guidance to be able to just pop into and whatnot.
Yeah.
I think it's a really important resource to have just when you're seeing these patients.
I guess a quick shout out is the Menopause Matter website, the professional section on Menopause Matters.
For that.
Yeah, I have to say, although I do most of my days around HRT and menopause care, I still use that go-to guide every single day. Again, sometimes all the drug names, even when I'm prescribing it day in, day out, it still sometimes is confusing.
See, that's quite nice, isn't it? I mean, I always worry about going, God, am I just not remembering these sort of things? Is it that complicated? But for someone who's an expert in this sort of area, it's nice to know actually they check it daily as well.
Can the public use that as well then?
The public can use it, and there's some brilliant patient forums, patient information guidelines on there too. Obviously, there is a section more for healthcare professionals, but a brilliant resource for patients. So I'll often accurate sort of text over, the digital way we communicate with patients, links to the Menopause Matter patient-facing websites as well.
Vicki, amazing. Thank you so much. This is a really nice run through about where we are in terms of women's health, what we're doing really well, what we can do better from there on. We've got we're trying to keep to our 20-minute schedule as always. Give us a couple of flavours about typical stuff you would see in clinic.
Yeah, great. I suppose we're talking about HRT and menopause.
Yeah.
I guess I am seeing a lot more maybe complicated HRT regimes when I compare my practice to a few years ago when I was still heavily doing a lot of women's health appointments. I think then maybe the treatments we're using are maybe getting a little bit more complicated now. I suppose I believe that's maybe for two reasons. One, I think we have got to thank actually kind of the Davina McCall, Dr. Louise Newson, the books, the TV programs, the information, and that's great because I think we have got women a bit more informed about options available. I do believe there's some misinformation at times with some of the things in the media. So I suppose more options are known to women to ask for, but I also believe that maybe we haven't treated some of those menopausal issues earlier, which has then led to the need to use much more complicated treatments. So I suppose actually, unfortunately, I think that goes beyond the competence of some GPs of actually these more complex regimes, not the common ones that we'd see necessarily on the Menopause Matter, but for some women extremely valuable and really, really useful and absolutely have their role. So I suppose often more complicated menopause care. I'll see, again, potentially discussing testosterone replacement in primary care. So that's kind of quite a key thing that I'll spend quite a lot of my day on. Again, probably other issues that I commonly see, I guess we still have period issues, endometriosis, the difficulty that we have in diagnosis of that condition, and probably the under-diagnosis of that as well.
Yeah, there's a huge spectrum there, isn't there, really, for us to look at from there on. Just thinking in terms of where next, where do you think women's health in primary care is going to head into? I'm already hearing from you that the level of complexity stepped up a degree. There's a myriad of medicines for example, HRT, for contraception. There's different even methods of it as well. What do you think, what do you see on the horizon that we should be mindful of? Particularly me, as in somebody who's trying to follow this and keep up to date.
Yeah, I think that's exciting. I hope we have sort of more training and scope to mean that we keep it in-house. I suppose maybe you might as well as me. I know we practice in different areas, but we're There's times we get more fragmented care. We have all our patients now, or a lot of them, going to our local pharmacy for contraceptive pill checks or pill starts. We have the Solway Clinic, excellent at providing sort of sexual health care.
Big shout to Solway.
Yeah,
Absolutely
absolutely amazing. And again, excellent obstetric gynecology clinic. But again, I worry that some of our care is getting fragmented out to other services. I hope we can keep it in-house more. And so I suppose with that, I guess there's an importance that we keep up to date, particularly I think around sort of HRT, contraceptive updates, newer options on the horizon. I think probably the use of testosterone and pelvic ultrasound scanning, I imagine we're becoming much more in-house and much more core primary care work to be done. But again, with that maybe comes with some funding negotiations and who is trained in interpreting this. I suppose I do believe probably endometriosis diagnosis is going to change, and I hope it does, and I hope we have more testing available over the next sort of 5 or 10 years.
Amazing to hear that, a rapidly developing field as well. I mean, we look at all of the other sections of primary care that we follow. I can't think of one that's evolving so quickly and has such a massive impact.
So from a patient point of view, though, when do they need to come to see the doctor? Like, because you said sometimes they come late. What sort of the early...
Go on, Paul. Yeah, no, good
early
shout.
thing.
Yeah.
I'm just thinking as a patient, because I don't know medical stuff, and I'm thinking there's all this stuff available, but how do they know I need some of that to help me?
That's really good. And I suppose what I would sort of urge people is there's so much, isn't there, on Facebook, social media, saying for help and care. What the thing is, if you're worrying, if you're starting to think about all these really expensive supplements that you feel something isn't right in yourself, still please use primary care. That's your first point of call. It's not that £200 collagen cortisol supplement.
The Amazon quick next day delivery.
Exactly, absolutely. So again, if you are feeling that there is something either with your cycles, with your mood, your mental health, your periods that are really starting to impact your life, if it's starting to worry you, again, we're learning more about the perimenopause, menopause, but if things are changing, you feel there is a hormonal imbalance in which you're starting to struggle or it's impacting your day-to-day functioning, please come and speak with us. We don't need to wait for the hot flushes to start. We don't need to wait for the night sweats. We don't need to wait for the periods to necessarily change. But please, if there are issues and it is impacting you, your well-being, your day-to-day life, like that's the time your GP wants to speak with you. There are options available.
I mean, we'll often hear the backlash, I suppose, on social media where it's like, I can't get through to my GP and things. I can't get through for them appointments. But
yeah, and I guess for me, that's where the digital triage comes in. I know I mentioned to you, Amit, the worry is that might put women off, raising, we're sort of, it looks like we're iMessaging what our women's health issue is, and that can feel embarrassing. I know I'm a patient, I'm a woman, it can feel a bit unusual to put on there, I have these issues, you don't know who's reading it, it can feel quite personal or sensitive, but please know that is being looked by a clinician, and actually these are issues we want to see, whether that is painful sex, a low libido, periods that are painful, periods that are really heavy. This is still really important medical information that actually there are possibly things that we can do. So although practices, we're now urged kind of by government to be using digital triage tools, that's still the forum to do it, and that is okay.
Good shout. Thank you, Paul. I mean, yeah, just highlights the extra dimension of all this. Last thing then, shall we, go on, should we pivot?
he likes his pivot bonus question. It's his bonus question.
Well, look, we've asked everyone who's come on. So the question being, what's one thing you'd like to see, an additional resource or one thing change in the NHS to allow us to be better clinical colleagues?
What, clinical colleagues rather than clinical staff for our patients?
Yeah. So what would you say is one thing you would like to see happen in the NHS, or one thing you'd like to make you a better doctor?
Almost the genie in the lamp. You get that one wish.
I'll put you in the spot now. You've already reeled out all of the amazing things you want to see, but go on, I'm going to pin you down to just one.
I would like the ability for all women to feel like they've never been dismissed. It literally tears my heart out when I hear a case that they have been sort of dismissed or they've not been listened to. That really upsets me. And actually, Amit, you've been great. You've said sometimes you worry in appointments, but actually, please don't worry about getting it right. It's okay to take time, check the guidance, check with your colleague, check with a women's health specialist in your practice if needs be. Just listen. And actually, so long as women don't feel dismissed or fobbed off, like that is my only wish. That makes me, honestly, it makes me mad.
You know what? I'll take that away. And it's one thing that I'd encourage our colleagues, clinical colleagues or trainees, anyone who's on the podcast, I thoroughly recommend that as well, because it does upset me when I hear from women who felt they've been dismissed, and I try and make an extra effort to just go in clinics. It feels as though that you still got concerns. Tell me. I'm happy to hear.
My husband, he's a GP partner with me in Brampton. I'll be honest, he is terrified of women's health.
Wow.
If he knows there's women that are coming to see him, he'll often maybe phone me when he's in work or call me into his clinical room to sort of chat through how we could manage it. And actually every time I say, it's okay, women just want you to listen. Like, it's okay, like, please listen, see the impact that it's having. And actually, it's amazing. He has quite a following of sort of women's health issues of women.
Fan club now.
Yeah, he does actually. And it's okay that you maybe haven't got the diplomas, you don't know the nice CKS inside out, you maybe not even heard of the BMS website. That's okay. Listen, see what the issue is, take your time. It's all right.
Big shout to Vicky's husband there on absolutely fantastic. No, really, really good. And actually quite nice reflections over the wins. We don't often celebrate them in primary care. You know this, Vicky, that we often worry about access, we worry about making sure patients receive really high quality care, and rightly so, because we need to. But actually, it's been really nice to spend time with you and speak about some of the wins that we've got in primary care,
we do.
and the huge breadth of stuff we cover. Yes, we need to do better, that's clear, but it's a really nice reflection with you, Vicky. So look, I'm incredibly grateful. Thank you so much.
Thank you
for coming in, sharing your thoughts, and I'd love to have you back.
Yes, please.
Thank you so much, Vicky.
Thank you.